Hello, my name is Aaron Lang. I'm an undergraduate student in the Health and Human Performance program at Berea College. This video is a presentation about Achilles tendonitis in a made-up patient. The video is being created for individual and dual sports, a course taught by Dr. Michelle Thornton Adler. In this video, I will provide a background on the made-up person who I am portraying as having this injury. I'll provide a background on the injury itself and the mechanism of injury in the sport of tennis. I will also perform a SOAP note, with SOAP being an acronym for Subjective, Objective, Assessment, and Plan. The SOAP note is commonly used in the physical therapy world as a very distinct and accurate way to figure out what is going on with the patient and to maintain patient records. In the subjective portion of the note, the patient will tell me what they are experiencing or feeling and what the reported pain levels are. It's not often reliable because different individuals will have differing pain tolerances, and each individual will have their own perceptual bias about what is going on with them. In the objective portion of the note, I will obtain measurements that are objective and observable. For example, I will obtain range of motion and muscle testing, strength testing measurements. At which point I will provide an assessment of what I think the injury is and what the possible outcome of the injury is. Then will come the plan, which is the recovery program that I will put together for this person. And in this case, I will be giving a home plan to the patient because I don't think Achilles tendonitis warrants coming into the physical therapist. So this is our patient. This is a Mr. Porter, who is a 50-year-old male, recently retired or fired. He's an avid tennis player and is in excellent physical condition. So the injury itself is an irritation and inflammation of the Achilles tendon here. As you can see, this is a graphic depiction of the ankle, including the bones and the Achilles tendon and some of the muscles. So the Achilles tendon attaches the muscles of the calf, which are very powerful, namely the gastrocnemius and the soleus, which connect through the Achilles tendon down through the calcaneus of the heel. The Achilles tendon is responsible for transmitting the force created by the contraction of the gastrocnemius and soleus to pull on the calcaneus to generate rotational torque about the ankle to provide plantar flexion. Plantar flexion is important for walking, for running, for almost any ambulatory movement. So how does the injury occur in tennis? So Achilles tendonitis itself is an inflammation of the Achilles tendon, which is usually caused by chronic overuse of the ankle without the ankle being adequately prepared for the amount of use that it experiences. Typically, this overuse consists of abrupt loading during movement, with sharp forces being applied to the ankle, such as with changes of direction on the tennis court and stopping and going. The stopping and going involves eccentric loading of the ankle and then rapid concentric loading, which places a lot of stress into the Achilles, which is responsible for plantar flexion. Also, improper and incomplete warm-ups can improperly prepare the athlete to exercise and not allow adequate blood supply to the area. Additionally, if there's a plantar flexion flexibility deficit, it can leave the Achilles to make up the stretch that's needed in the calves that might not otherwise be had if there's a flexibility deficit. Additionally, changes in footwear can leave the ankle unsupported and vulnerable if the stabilizer muscles of the ankle are not strengthened prior to the change in footwear. So now that we understand a little bit about the injury, let's get into the subjective portion of our analysis. The patient is a 52-year-old male reporting pain near his left heel with movement. He reports no history of injury to the affected ankle, but recently quadrupled his time per week playing tennis. He reports pain has increased in the past week, despite using such popular technologies as kinesiotape, cupping, foam rolling, and ice treatments. He reports no pain currently, but does report a 6 out of 10 pain during strenuous activity, which worsens for a period after stopping. The patient has not altered his activity levels despite worsening of symptoms. The patient had to replace worn-out shoes with inferior quality shoes than he is accustomed to. The patient also reports moderate stiffness and tenderness that is variable throughout the day. Fortunately, the patient reports a 2 out of 10 pain with walking on days that he has not played tennis. Finally, the patient is right leg dominant. Now for the objective. The patient is tender to palpation over the Achilles tendon with a sharp 5 out of 10 pain. He has no deformity, no bruising, only mild swelling, and no ecchymosis or discoloration. His active range of motion is limited in all 4 planes of ankle, which are plantar flexion, dorsiflexion, where the toes come towards the knee, eversion, where the bottom of the foot goes out to the outside of the body, and inversion, where the bottom of the foot comes towards the midline of the body, with the left compared to right, meaning that the left was worse than the right. He experienced pain with both dorsiflexion and plantar flexion. At this point, the patient finally remembers that he has had ankle injuries in the past and has had tight calves as long as he can remember, probably because he doesn't like to stretch. His passive range of motion is limited in dorsiflexion, but within normal limits for all other planes, which tells me that it's not a lack or it's not an obstruction in the joint causing the decrease in movement, but rather it's pain or a weakness of the muscles or possible swelling. Manual muscle testing or strength testing yields no strength deficit, but produces pain with plantar flexion, as is to be expected with Achilles tendonitis. Finally, the patient presents with pes planus or flat feet, which is known to cause or to be associated with Achilles tendonitis. So my assessment, my diagnosis, is that, as we already knew, the patient has moderate Achilles tendonitis and should refrain from intense activity, but can walk, which is very good. The patient's differential diagnosis, which are the other conditions that might possibly be the injury and should be monitored, are the Achilles tendinopathy, something other than Achilles tendonitis, or a possible Achilles rupture. Now for the fun part, the plan. So for our patient, Mr. Porter, we recommend RICing first. RICE is an acronym standing for Rest, Ice, Compress, and Elevate. I recommend that he performs the RICE method until pain with exercise subsides within 1 to 4 weeks. If pain persists past 4 weeks, then Mr. Porter should see a radiologist for MRI for possible rupture. For rest, cease strenuous activity and especially rapid movements. Ice. Use ice as a pain control measure if needed for no longer than 20 minutes at a time. Use a compression wrap if swelling persists around the ankle, or wear several pairs of tight socks. Elevate the ankle while sleeping, if possible and if comfortable. Especially continue this as swelling persists. Begin stretching when pain becomes tolerable. The images and the instructions will be included in the home plan following this. Begin strengthening when pain becomes tolerable. Begin functional training progression when pain is reduced to tolerable with activity, as will be discussed later as well. Continue activities of daily living, such as walking and bicycling or taking care of yourself, as long as pain stays tolerable or less. Report for follow-up in 1 month. Schedule immediate follow-up if condition changes considerably, for better or for worse. If patient reports with no pain in 1 month, the patient will be cleared to return to activity, but if pain persists, continue treatment. And further conditions for release will be outlined later in this presentation. Finally, encourage the patient to continue a healthy lifestyle even after pain decreases to prevent injury and prevent other injuries. So for each of the following videos with the stretches, perform each stretch for 20 seconds for 4 sets, twice per day. Increase if bearable. With the strengthening, perform 2 sets of 10 repetitions each day, then add 1 set per day each week. With the functional movement training, every other day perform the movement ABCs as I will describe, progressing gradually from walking to jogging, then to running. So begin with walking the ABCs until pain is intolerable in each session. When ABCs, uppercase and lowercase, the whole complex, can be walked in one session, begin jogging ABCs. When the ABC complex can be jogged, begin running or cutting. Continue with ABC training even after the injury is rehabilitated. Also begin incorporating jumping and ballistic training and warm-ups when jogging ABCs is tolerable. Begin balance training when walking ABCs is tolerable. Follow the progression outlined in the following video. This is an example of a straight knee calf stretch. With the gastrocnemius crossing the knee joint, stretching the calf with a straight knee will place an excess stretch on the gastrocnemius compared to the soleus. And as I'm describing here, don't push the knee to the outside or to the inside, but keep the knee directly in line with the foot for the stretch to get best stretch on the gastrocnemius and not put you at risk for injury. The bent knee calf stretch is for the soleus, which does not cross the knee. So stretching the calf in this way places greater emphasis on the soleus. Additionally, the yoga pose downward facing dog, in which the heels are pushed down, and also walking the dog, pushing one heel down at a time, is a good way to warm up the ankle joint. Here I demonstrate strengthening exercises. The first is the heel walk, which you will do for 25 meters to begin. Consider that a set of 10 and work with the ratio. This is the toe walk. This is an inversion walk, where you're walking on the outside. That's a foot. This is an eversion walk, where you walk on the inside of the foot. These are calf raises, which can be performed with 2 legs. It can be performed holding other objects. And this is the single leg calf raise, progressed from double leg to single leg. Additionally, this is the balance training. In this portion of the training, here you see me doing tree pose. Begin by standing on one leg, and then stand on one leg with the hands on the hips or with the eyes closed, or both. When this has become easy, over the span of a few weeks, you can grab an object such as a pillow or foam pad to place underneath your foot to increase instability, as demonstrated here. In this video, I demonstrate a hopping progression, but I left out the most important part, which is beginning the hopping on both legs and performing each of these hopping exercises first with both legs. This one is a single leg, or it would be a double leg up and down. This is a lateral hopping. This is forward and back. And like I said, begin each of these with 2 legs and progress to single leg. Additionally, a dynamic warm-up can be performed before or in conjunction with these activities. One such great exercise is the skip, the A skip, which can be performed like this, only with a lot more intensity and rigor. At this point is where you'll progress to my brainchild, which I'm calling ABC movement. This green rectangle indicates an area the size of a tennis court, and the athlete will write the ABCs using his body, facing first just forward, making the shape of an A, first walking and then coming back to cross the A. And then the athlete will make a B shape, however he chooses to make his uppercase B, and then C and D, and you get the idea. And the person will progress from walking to jogging to running, and eventually to cutting. Finally, the patient will be cleared to return to full participation in tennis and can stop attending therapy when he can perform the ABC complex at full speed with no reports of pain or appearance of instability, or of course if insurance stops paying for treatment, or if Mr. Porter can no longer afford the therapy, in which case we would have to end treatment early and provide a more in-depth home plan. These are the resources I've used for this project. I hope you've enjoyed the presentation and learned something from it. Thank you.